introduced by the American College of Gastroenterology in 2008, but this was specific for African Americans, and this was due to increased incidence, early onset disease, and mortality in the African American population. And then I'm sure, as people remember, in 2018, the American Cancer Society came out with age 45 for everybody for average risk screening. And finally, in October 2020, the USPSTF introduced a draft recommendation, again, suggesting that everyone be screened for colorectal cancer at age 45, meaning at average risk patients, so no symptoms and no family history. So next slide. So people, I'm sure most people on this call are probably familiar with the SEER registry. It's the Surveillance Epidemiology and End Results Program, which is a national cancer registry. And you can see here that there are different registries that can participate in SEER. One of the most common SEER registry analyses is SEER 18. So that's 18 registries across the United States. And you can see most of these on the map here. SEER 18 is good because it has actually expanded race data compared to SEER 9 and SEER 13. And we use SEER 18 for most of our analyses, which I'm going to get into detail starting now. So next slide, please. So the first study I want to talk about is entitled Trends in the Incidence of Colorectal Cancer in the US Among Those Approaching Screening Age. We just published this in 2020 in JAMA Network Open. And what we did here was we used a unique methodology to analyze SEER 18 incidence rates in high definition 1-year age increments. So prior studies really pooled patients together in blocks, in age blocks, for example, 30 to 39, 40 to 49, et cetera. And the question that we wanted to ask is, what is the increase in colorectal cancer incidence rates from age 49 to 50 when large segments of the population begin average risk screening? So we had a lot of cases through this large national database, about 170,000 cases. And what we found, kind of the take-home point, was that there was a 46% increase in colorectal cancer incidence from age 49 to 50 alone. So that's really a steep incidence rate. And these findings are really consistent with pre-existing colorectal cancers diagnosed with screening uptake. And I think the bottom line is this supports that there's a large undetected preclinical case burden in those younger than 50, and that this is not really reflected in SEER incidence rates because these cancers are ultimately found with screening at age 50. But they're kind of lurking in people in their mid to late 40s and possibly even earlier. Next slide, please. So this is our main data table here, and on the y-axis we have incidence rate, and on the x-axis we have yearly age, so age 30, 31, 32, et cetera. And you can see between 49 and 50, there's this steep inflection, 46.1% increase, which is obviously an outlier compared to any of the other age transitions. And if you actually look at case counts, I think this is kind of important to give you some impact. There are approximately 129,000 cases of colorectal cancer extrapolated to all 50 states for patients between the ages 45 and 50 during our study period, which is just from 2000 to 2015. You're talking about an enormous amount of colorectal cancer that could potentially be either prevented or diagnosed at an earlier stage with earlier screening at 45. Okay, next slide, please. So this age 49 to 50 incidence rate increase was actually reproducible across all US regions in men and women, white and black populations, and for both colon and rectal cancer. And screening at age 50 really unifies these different populations. And this supports that this increase we're seeing between 49 and 50 is due to a screening effect as opposed to advancing age alone. So next slide, please. So you can see here that for geographic regions, South, Northeast, Midwest, West, there were some variations, but the same inflection is seen. Next slide, please. For men and women, you could see that the bump was a little bit bigger in men than women, but again, reproducible between men and women. Next slide, please. And then in black and white populations, basically exactly the same inflection, although you can see that the absolute incidence rates per 100,000 years are higher in blacks compared to whites, meaning the orange line is above the blue line, but that inflection is still there. And then next slide, please. And then you can see for colon and rectal cancer, again, similar inflection, although it's a little bit muted in rectal cancer. And we believe that's because rectal cancers are probably more likely to present with symptoms prior to screening detection. So they may be detected before age 50. Okay, next slide, please. So this is an important slide because it looked at stage stratification. And if you see that box on the top right, the most common cancer, the steepest inflection was actually in situ cancers, 140%. But if you look at the y-axis, you could see that in situ cancers were very uncommon compared to the other stages. So the steepest inflections were seen in localized, which is orange, and regional, which is blue, and then distant stage was actually pretty flat. So the key points here are that about 93% of colorectal cancers diagnosed at age 50 are invasive or beyond in situ stage. And that localized cancers, even though they're quote unquote localized, they still have a 10 to 11% 5-year mortality, and most require surgery. So this really argues against length time bias phenomenon in terms of the detection of these cancers. And it's important to note that localized and regional cancers can be associated with psychological distress, economic burden, and impaired quality of life. And in terms of distant stage cancers, it's not surprising that there wasn't a steep inflection between age 49 and 50, because it's less likely that these are going to be picked up on a routine screening exam. They're probably going to present with symptoms before someone has screening, although not in all cases. Okay, next slide, please. So take-home points for the study, the steep age 49 to 50 incidence rate increase certainly supports that there's a large preclinical cancer burden for those in the mid to late 40s, and that these cancers are not reflected in observed SEER incidence rates. And if you look in the literature, there have been a lot of arguments posed against earlier screening at age 45, stating that the incidence rates in people 45 to 49 are much lower than those 50 to 54, but that's because we're not finding these cancers until age 50 when they're screened. So the kind of the corrected incidence rates, the true incidence rates for people in 45 to 49 is significantly higher. But when you're comparing 45 to 49 and 50 to 54 with regards to SEER incidence rates, you're really comparing apples to oranges, because people under 50 are not subjected to screening in order to detect their preclinical cancers, whereas people 50 and older are. So that's really kind of the take-home point here. Okay, next slide, please. So the next paper I want to talk about that we just published in Annals of Internal Medicine a few months ago is contributions of adenocarcinoma and carcinoid tumors to early onset colorectal cancer incidence rates in the United States. And the bottom line with this study is this was the first study to break down early onset colorectal cancer by histologic subtype. So prior studies really pooled all early onset colorectal cancer into, they didn't make any distinctions between different histologies. But it's really important to focus on adenocarcinomas because that's the focus of colorectal cancer screening and diagnostic testing. And you also need to acknowledge carcinoids or neuroendocrine tumors, because these are actually classified as colorectal cancer in SEER databases, but they obviously have a distinct pathogenesis and are managed completely differently from adenocarcinomas. So what we did is we looked at incidence rate changes and changes in proportion, primarily for adenocarcinomas and carcinoids from 2000 to 2016. Okay, next slide, please. And what we found is that we basically confirmed that adenocarcinomas are in fact steeply increasing in young patients. So the steepest was in rectal adenocarcinoma in 20 to 29 and 30 to 39-year-olds, a 39% increase from 2000 to 2016. But you could also see that there were steep increases in 40 to 49-year-olds as well. So 16% increase in rectal adenocarcinoma and 13% increase in colon adenocarcinoma. So again, I think this supports earlier screening at 45. Okay, next slide. But you do have to acknowledge carcinoids because they did represent approximately 4 to 20% of all colorectal cancer cases, depending on age group and calendar year. And in fact, they represented between 8 and 34% of rectal cancers, depending on age group and calendar year. Although I should mention that colon carcinoids, anything proximal to the rectum, were incredibly rare. And importantly, all age groups had statistically significant increases in rectal carcinoma incidence rates over time, which were higher than the corresponding adenocarcinoma incidence rate increases. So for example, when you compare kind of the early 2000s to about 2016, there was a 113% increase in rectal carcinoids in 20 to 29-year-olds and 159% increase in 50 to 54-year-olds. It's a typo. It should be 50 to 54 for rectal carcinoids. Okay, next slide, please. So this slide, I don't have the pointer, but the bottom line here is that in the columns you have colorectal cancer, then colon, then rectum, and then kind of going horizontally you have age group. And purple represents adenocarcinomas, green represents carcinoids, and yellow are other types of tumors. And what you could see here, what we're trying to show here is the percent contribution to overall cancer incidence rates. So if you look at the rectal column all the way to the right and kind of look down, you can see that there's a lot of green there for each of the age groups, especially in 20 to 29-year-olds and 50 to 54-year-olds. So you could see that carcinoids really do make up a decent proportion of rectal cancers in those age groups, although purple pretty much dominates all of these panels. Next slide, please. So the take-home points from this study are that we confirm that adenocarcinomas are steadily rising in young patients, including 40 to 49-year-olds, which supports earlier screening at 45. And that although carcinoids are rising at a faster rate than adenocarcinomas, it's really important to state that the overwhelming majority of early onset colorectal cancers are in fact adenocarcinomas. And these are the driving force behind the young onset colorectal cancer burden that we're seeing. But I think going forward, it's really critical to always look at adenocarcinomas independently from carcinoids in order to get a more accurate measurement of outcomes from our efforts to reduce adenocarcinoma risk. So if we include carcinoids, that could certainly bias results. So for example, if we're looking at incidence rates 5 years from now, and we're like, oh, colorectal cancer rates are continuing to increase, it may well be that carcinoids are driving that increase and that adenocarcinomas are decreasing and that our efforts are working, our preventive efforts by screening and early diagnostic testing. So it really is important to look at adenocarcinomas. Now I'm on to my last slide, please. So conclusions, I think hopefully I've shown that analyzing SEER data in new ways can allow us to understand implications of screening at age 45 at 50. I think these two studies that we recently published clearly support screening at 45. And I really hope to continue these types of large database analyses in Colorado and work with anybody that's interested to do more work in this area. And again, I'm really excited to be joining the team here in Colorado. And thanks for the invitation.
That was great. Thank you so much, Dr. Karlitz. And we are certainly looking forward to you joining us here too. So as I've already mentioned, if you guys do have questions for Dr. Karlitz, please feel free to put them in the chat and we will get to them at the end. On to the next presentation, which for this group, the presenter really needs no introduction. So Andy Dwyer is the director and one of the founders of the CCSP program at the University of Colorado Cancer Center and works to implement the country's largest screening patient navigation program. Andy also serves on many local, state, and national committees and coalitions and is an expert advisor focusing on the work related to colorectal cancer. So Andy, I will go ahead and hand it off to you.
All right, so thank you, Ali, a ton. And I just want to say thanks to Dr. Karlitz joining in Colorado. Jordan and I had a chance to work together at the in CCRT, and then Ali, a big thanks for ACS and all of the support for moderating today. And I do want to just say the doorbells you were hearing were all of the people who were entering the meeting today. So I think we heard about 81 door knobs or door rings. So thanks for your patience, but Chloe and team have got that all figured out right now. So, and a huge thanks to Chloe Fields and Elsa Weltzing, who've really been supportive of all of the work for the CCSP program. I'm going to talk a little bit about the statewide screening effort for the medically underserved, a little bit about data in Colorado, and then hand it off to many of our partners then today to talk about ways for us to really engage. So Chloe, can we go ahead and go for next slide, please? I'd like to start off the presentation by just showing a picture that I received from Dennis Anand's family yesterday. So they were out in full force, really celebrating Dennis and his legacy and his memory with their whole neighborhood around March of CRC Awareness Month. So Dr. Anand's wife, kids, grandchildren are all in the photo. So we just received this last night, and I just want to remind everyone that folks like Dr. Anand, Dr. Karlitz, Hans Elzinga, many of the GI providers out in the community who've really been advocates for us have really made the case and champion colorectal cancer screening. And so we really just want to continue in that legacy and that work, and a huge shout out. We missed Dennis tremendously, but a great ode to him and his family for really keeping the discussion as March as CRC awareness and really talking about the importance of screening moving ahead. So next slide. So I want to share a little bit about our statewide screening program at a glance, a reminder that we have been one of the states that has had the great opportunity with leadership to really address colorectal cancer screening as a priority with funding through our statewide competitive grants program. We really had, over the last 10 years, had from 2007 to 2013-ish, had monies to do direct services. We were doing, definitely paying for colonoscopies, stool-based testing, treatment, as well as infrastructure support for navigation and health systems work. And in about 2014-15, when ACA expanded, the program really moved for evidence-based intervention around barrier reduction, access to care, with navigation as really part of our focus moving ahead. So we're really thankful that we have statewide money that we've been able to apply for to keep this work moving in Colorado, and really are thinking about sustainability efforts moving ahead, which we'll talk about in this presentation and others will address as well. So next slide. So with our statewide program, as all of you know, we're really about improving colorectal cancer screening rates. We're really in walk with a number of our national partners around increasing screening to national goals around 80%. We'll talk a little bit about the data in Colorado, creating a healthier Colorado, and we're really doing this through fostering of partnerships, and even with our navigators engaged in our work. We've now navigated over 30,000 people into preventive screening who otherwise wouldn't have access to care. So I really do think from an equity lens and from the discussion that CCSP, the WWC program, and other programs have really thought about equity over the last several decades, and we really want to keep this front and center within our Colorado communities. Next slide. So moving the other way. So we're really, actually, Chloe, we're going to go back one more, I think. Oh, sorry. So going ahead, next slide. One of the things that I do want to just underscore is that we're really also, through our coalition work, through our CCSP program that's housed at the university in partnership with many of our safety net clinic systems for a statewide screening approach, is we really do keep track of what's happening with the data in our communities and statewide. So I give mad props to the CDPHE team who've taken a number of data sets to really look at screening rates, looking at socioeconomic status, and then looking at ultimately the impact of colorectal cancer diagnoses. And so this is one of the type of maps that we're utilizing. This one is now being updated currently, where we can look at the darker colors, really looking at later stage incidents. The smaller the dot, the lower the screening rate. The bigger the dot, the larger the screening rate. And then the etched areas really denote areas where we see specific socioeconomic in terms of the overall poverty level within a state or in a region and the like. And so we really are encouraged by this type of data. We use this in our planning of CCSP, and then working with all of our navigators, health centers, as well as a larger community to talk about what's happening through in the state and where do we devote resources and how do we really do things like awareness campaigns, as well as really thinking a little bit about what do we do for access to care in general. So I really encourage all of you to really think about these types of maps, what's going on in your community, even if you're one of those great places that has great screening rates, lower incidence, later. There's really a lot to be said about keeping your community healthy and keeping the pedal on the metal. And even for those areas of the state, such the northeast part of the state where we're seeing later stage incidents, lower screening, about what can we do to really help leverage from our community partners and state partners to really think about increased access to care. So just a shout out, and we'll be continuing to share this kind of data. Next slide. And I'd really like to thank the CDPHE team who provided me this updated slide. And I know that we have more data coming, a little stalled with COVID. But one of the things I want to say is that overall, Colorado has made great gains, I think, in the last 10 years for preventive screening, especially within the medically underserved communities. We're seeing over 70 and 80% thresholds of screening within populations, particularly in those who are insured, those who have Medicare, those who are older adults, older adults from 70 to 75. But we still have a lot of room to go in terms of meeting that overall 80% mark. So you'll see that etching is at around 70% of our statewide by all types of insurance, the breakdown by different types of demographic. Overall, all things combined, we're still a little less than 70% of our population screened who are eligible. A reminder, especially with Jordan's talk, that this 50 is going to move likely to 45 with USPSTF changes. So we'll still be looking at that group of folks as well. But I really just want to show that ultimately, even in the uninsured, we are well below, we've made great gains, but ultimately we're still well below where we should be in terms of types of screening rates that we're really looking at to reach that 80% for all eligible populations. So a reminder, I guess, again, that as we look at different communities within rural and frontier communities, working with the Hispanic community, as well as other community of color, really thinking about how do we address and really think about access and equity. That's something that remains forefront to all of us, I think, on this call. And that's exactly what our statewide screening program is about. So we will continue to share data in the planning and really thinking about how do we make great gains in our state to be, again, one of the healthiest states in the nation. So next slide. So I'd like to share just a quick snippet is that over really the last 10, 15 years, we have great Dwyer, I'm seeing, so the CCSP, oh, I'll go back to a slide earlier, or sorry, the question here, Ali, I don't know if we want to address it here so I don't lose track of it. But ultimately, we have navigated over 30,000 people into preventive screening from 2006 to 2020. I think what has helped Colorado become a leader in navigation and part of the work to help frame CDC work, as well as the funding in other areas, is our no-show rates are well below 90% for screening for the medically underserved, bowel prep, and ability to reach the CCM. But ultimately, we're really starting to see making a business case around preventive screening is that we're also able to detect the type of polyps that would otherwise become cancer, finding cancer earlier, and then ultimately with the amount of money we're putting into preventive screening, what we would otherwise spend in treatment, we're actually seeing great cost gains in the state as well. And not to mention, of course, the quality of life and impact that it has within patients. So again, this is something and fodder we're using to talk about sustaining our work, and then also has been great information for the national partners and thinking about programmatic planning. So Ali, did you want to, was there something right there that I could address quickly?
I think it was just talking about the different screening options. So the question was specifically talking about CT colonography. Noticing that you had referenced just a colonoscopy as a screening method. So do you want to just real quick kind of touch on?
Sure. And I think that's a great question. What I would say is that CCSP has definitely been a advocate of the best screening test is the one that gets done well. It gets done well. And what I would say is right now that our grant is funded to help navigate people into colonoscopy. But we do support infrastructure support around all the screening modalities, stool-based testing, emerging technologies, and then CT colonography is on the list as well. So our program isn't funded to support all levels of navigation or all of the different types of tests directly in that navigation sphere, but we are moving, hopefully in the next iteration of the grant, to providing fuller navigation and resources for all screening modalities. But I do want to just pick up on the point. I think that the best screening test is the one that gets done and gets done well, as I mentioned. But I mean, the USPSTF guidelines do exist for the average risk population, talking about a variety of screening tests. And not everyone will have a colonoscopy. Stool-based testing isn't always the right option for different folks as well. But with our medical advisory board and technical assistance team, we do talk a lot about the different types of approaches. CT colonography, I think, is something that within our medically underserved communities, we've had a harder time accessing. So we definitely talk about it as an opportunity for care, but in terms of what the grant is paying for into navigation right now, it focuses on colonoscopy. But it's a great question, and we can take more at the end. Okay, next slide. So in terms of really where we're moving, the CCSP program was really about colorectal cancer for the first 10 years, but we've really taken a focus since 2018 to integrate the implementation of lung cancer screening pilots, sustainability of navigation, and then ultimately looking at family history and looking at the specific types of approaches where we can identify high-risk strategies for identifying those who need screening options sooner than later, and then really looking at population-based health in terms of risk assessment, and then ultimately really trying to align our work with the breast and cervical program, and then also the workforce development movements at CDPHE, as well as other types of alliances in the state. So that colorectal screening has been really the foundation, but really moving to integrative preventive care and really thinking about an opportunity for whole person care versus body part is something that we're really committed to, and we've really tried to add into the approaches of our work. Next slide. And I just also like to remind people that, of course, that with our work, even in the first 2 years of this last grant cycle, which is sunsetting in June, is that we really have done a great job, I think, reaching men and women at equal numbers. We are paying attention to those who are under 50, who are at higher risk, and those guidelines will help approach that as well. Really looking at the demographics within our state and making sure we're reaching the populations with, over 40% of the folks being Hispanic, reaching about the state average, about 7% being African American. And so really thinking about who we're working with and that we're really trying to provide access with our demographics, and that data telling that story, I think really helps share about the purpose and really how we are an equity-based program. And then again, I think to the larger component of sharing that this type of a program for prevention really makes an impact on lives, but also cost, and having great outcomes with that polyp removal, as well as showing the good outcomes because of the navigation, remain critical. So there's a couple of pictures of different navigators and folks from throughout the state, and I just want to say that I know many of you are on. We have over, I think, 20 clinic systems participating, almost 100 clinic sites throughout Colorado, and we're going to continue to work with all of our state partners. So a shout out to all of our navigators and people in the clinic systems who are making this really work. Next slide. And I just want to also do a quick mention that, of course, we are going to be spending a lot of time on talking about returning to screening, the impact of COVID. There's national data that does show the depletion of screening over the time where we saw the elective procedure ban. We know there's a lot of pent-up demand and need. We know there's people who had signs and symptoms who are at high risk, who delayed screening, as well as the average risk population. And I just would say that I think what we're seeing in Colorado is consistent with the nation in terms of really looking at access and needing to move that forward. And it's going to be a big call to action for the coalition and many of us working in the field moving ahead. Next slide. And then speaking to that, of course, I just wanted to show that through March and April of last year, compared to 2019, we did see a slowdown and a real reduction. But since August, we have continued to see similar rates of screening as we did in 2019. So I think, again, that is a huge ode to many of you really working this, but we know this still continues to be a great battle for navigators is trying to manage COVID as well as cancer prevention and other chronic disease management. So our program will continue to work with all of you to provide great access to different types of support and resources to help get people back into screening. So kudos for all of you where that orange line is starting to tick up. We've definitely seen from August into the fall, that's trajectory continue as well. Next slide. And I'd just like to say a bit about sustainability. I think with our program for development of workforce around the role and function of community health workers and navigators, it's something we're taking near and dear. We'd like to really help think of policy and legislative aims to really provide fair, equitable wages, to really make sure navigation and CHW work is part of the workforce development that we're nurturing, and using the data information from our program to make that case, but also working with all of our direct clinic sites in terms of how do they make that case internal is something that we're working, and I think that's really going to help inform our statewide and national efforts, such as the National Navigation Roundtable and others as well. So next slide. And looking to the future, I just want to just say that again, we are in the third and final year of our 3-year grant. We are sunsetting at the end of June. The one thing I would say is that I think there could be, if there is a fiscal state of emergency, that's a difficult time for programs like CCSP. There's the possibility of extension funding to year in 2022. We've learned from our Board of Health and from CCPD team as they're looking at their recommendation that we will likely be recommended for an additional 2 years of funding. So it would probably be to 2023. We're still waiting on that, but the recommendation has been made. That we have strong champions within our groups, so we know that there's a lot really happening in this idea of integration. The effects of COVID-19 are not lost. Integration is going to be key in working with all of you in the field. And again, we should know by mid-March if we are recommended for an additional couple of years of funding, and in that time we'll be thinking about our sustainability cases as well. But I just want to say that again, as Ali noted, that we are one of the largest statewide screening programs in the country. And we really hope to continue to be a leader in this work. And thank you to a number of our partners who are involved. And Ali, I'll pass it back to you.
Great, thank you so much, Andy. And thank you to your whole team and all of the great work that you guys are doing. So I popped a couple links in the chat. One is to the National Colorectal Cancer Roundtable Reigniting Screening Playbook that Andy referenced in her presentation. And then ACS has partnered with NCCN, which is the National Comprehensive Cancer Network. And we have developed a partnership to create a fact sheet around resuming cancer screening. So those could be 2 great resources for you guys throughout the state and your teams. And in addition, Chloe has reminded me that we do have an evaluation and a survey today. So if for any reason you need to hop off early, please give us your feedback, your thoughts, and your comments so we can continue to give you the material and information that you're looking for. All right, now on to a lot of the partnership work that's happening across the state. So next we're going to hear from Christy Cahill, who is the Executive Director of the Colorado Cancer Coalition. And Christy has dedicated her professional career to working with cancer-related nonprofits and organizations. She's been involved with the Cancer Coalition in a variety of capacities since 2009 and is now the Executive Director. So I'll turn it over to you, Christy.
Thank you, Ali. Can you hear me okay? Okay.
Yep.
Great. Next slide, please, Chloe. Thank you, Andy, for the invite to be here today to talk about the coalition and the way that people can engage with this work. So the Colorado Cancer Coalition is the statewide network for cancer-related organizations and individuals dedicated to saving lives and improving the quality of life for all Coloradans touched by cancer. Our membership includes people from all across Colorado and from all across the continuum of care, from prevention of cancer all the way through survivorship and end-of-life care. So if you work in cancer or you are a survivor or a caregiver, there's a spot for you to engage in the coalition and provide your expertise and your valuable voice to move cancer programming further along in the state. So next slide, please. So we re-entered the policy arena in 2020. Next slide, please. And we've received a grant from Fight CRC. We're one of their first Catalyst grantees. And the goal as a Catalyst grantee was to either focus on small policy or big P policy, like at the legislative level, around lowering the screening age to 45, and then also covering the cost of a colonoscopy after a positive stool-based test. And so we convened a group in 2019 and early 2020 to work on a bill that was moving along in the legislature. It was about to be heard. It made it through the House of Representatives. It was about to be heard in the Senate committee when COVID hit and the session paused. And so due to the session pausing, as well as to our current governor's issue with mandate bills, that bill was postponed indefinitely during that session. So next slide, please. So from learning from that, as well as the USPSTF coming out with new recommendations new draft recommendations, they haven't been approved yet, around lowering the screening age to 45. Our group met and decided that we were going to reprioritize what we needed to focus on. And so we started looking at trying to establish a comprehensive screenable cancer program, and doing that one as big P, and then as little p, looking at the cost of a colonoscopy after a positive stool-based test. So we had a bill that was going to go through the session this year. It has, unfortunately, it will also be postponed indefinitely. And so we'll be going back to the drawing board with stakeholders, but I'll get to that in a second. In terms of covering the cost of a colonoscopy, there should be a new bill this year around how Colorado handles mandate bills. And so that could possibly be something in 2022 that we look at. We're in the process of securing data to figure out how big of an issue this is in Colorado and make a game plan from there. So next slide, please. So this is where you all come in. So we will be, in the next few months, reconvening all of our stakeholders from across the state to talk about, next steps and priorities for Colorado of where we should go in terms of cancer screening for the medically underserved. We'll also be doing some media pushes around different cancer types. And so we need stories from patients, from physician champions, from navigators. We need as many stories as we can build up so that as we prioritize, what's best for Colorado and everyone that lives here, we have stories to pull from and can plug them in with media in different regions of the state. And if we have another bill, then we can reach out for testimony and things like that. So you'll hear more from opportunities of how you can share your story and engage with these both small p and big P policy ideas. Next slide, please. So I'm just going to talk a little bit more about what we have been trying to accomplish in this legislative session. So we were looking at trying to establish a comprehensive screenable cancer program that would focus on breast, cervical, colorectal, and then eventually lung and other screenable cancers as the fund allowed and as the fund grew. The goal being to provide a more equitable access to care for Coloradans. Next slide, please. Next slide. And so you all probably know most of these, next one, most of these numbers. So colorectal cancer is the second leading cause of cancer deaths. Lung is the first leading cause. And so again, we're just going to reconvene stakeholders to get everybody at the table and really determine where we should go that would be in the best interest of Coloradans. Colorado is unique in that cancer is the leading cause of death. And so we all need to work together to try to reduce that. So next slide. So if we're able to, do these small p changes and big P changes, hopefully Colorado would end up with a comprehensive cancer screening program that focuses on the whole entire person. And then we'd be finding more cancer types early. Then, and as you all know, colorectal cancer screening can prevent cancer. So just working towards more comprehensive care for all of Colorado. Next slide. So as I was mentioning at the beginning, there are a lot of different ways to engage. After me, you'll hear from our colorectal cancer task force about all the different great work they're doing. We host quarterly cancer partner meetings, and that next one's coming up on April 22nd. We do an annual symposium every year, and that will be November 4th and 5th. We have about, 200 people attend that, so it's a great networking opportunity. We even were able to figure out some networking in the virtual world. So stay tuned to hear what that will look like. And We also have a webinar on April 13th on disparities in cancer care. We do webinars every few months or so. So the website's there. I'll also put a link for the webinar into the chat box. But there are many ways to engage, and I'd love to see you all at future Cancer Coalition meetings. And so that's my last slide, so I will give it over to Allie.
Thank you, Christy, and thank you for all the great work that the coalition has done on this. I mean, obviously we know that big P policy and passing legislation can have a huge impact on the populations that need it most. So we are on to our final presentation here. So please add your thoughts, comments, questions to the chat, and we will get to that in just a second. So our final presentation comes from also part of the Cancer Coalition, our colorectal cancer task force. So the colorectal cancer task force is led by Ian Kahn and Meg Phillips. So Megan Phillips is the colorectal cancer control program manager at CDPHE. She has an extensive background in quality improvement and research in both pediatric and adult gastroenterology, and she's a current co-chair of the task force. And then Ian started his work with the coalition as a member of the task force in 2016 while he was working with the American Cancer Society. And he quickly realized that this was his passion. So he continues to be a co-chair of the task force as a volunteer while working at CDPHE also. So I will turn it over to Meg and Ian.
Hi, can everyone hear me okay? I've been having audio issues all day.
Yep.
Yes.
You're good.
Okay, great. I have two screens here, so I'm going to try to focus on one. And Ian is going to take the second half of our slides. We'll be pretty brief, but we just wanted to round out the discussion about the colorectal cancer task force and kind of some of the work that we're doing with our partners. You can go to the next slide. So Christy already talked a little bit about how you can get engaged with the colorectal cancer task force. It's the only statewide group in Colorado that allows peer sharing, learning, engagement, and collaborative action to support colorectal cancer initiatives from screening and prevention to diagnosis and treatment. We have a few different goals. We have 3 work group that take place under the task force that are led by our members, focused on colorectal cancer awareness, supporting employers and employees to get screening, and then provider support. These work groups are where the actual work of a colorectal cancer task force kind of happens. And over the next couple of slides, we're going to talk about what we're currently working on and some of our future initiatives. Next slide. So the colorectal cancer awareness work group has been very busy over the last several months, and obviously very busy this month. It's a 7-person work group that has been focused on promoting colorectal cancer screening awareness throughout Colorado. Some of these initiatives include lighting buildings blue in March, social media promotion and strategies, and supporting community events like the Colorectal Cancer Alliance's Walk to End Colon Cancer. The work group also coordinates over awareness strategies like obtaining a governor's proclamation regarding March as Colorectal Cancer Awareness Month, and has also hosted a few different radio talk shows regarding getting back to screening after COVID. We envision kind of this work evolving into a more community-based strategy and outreach, focusing on equity and coordinating initiatives with national partners in the coming months. Ian, do you want to take over and do the last couple of slides?
Yeah, sure. And to kind of follow up on Meg, what Meg was talking about for this month, just this morning we learned that Ball Arena will be lit blue this week. And I believe there's some other prominent buildings throughout the Denver area that will be lit blue for colorectal cancer. So if you're driving along 25 and that's what you see, or that you notice that's what it is. All right, so for the employer and employee education work group, it's made up of 8 task force members, and you'll kind of notice that we put how many members are working on each activity, and know that a lot of these folks are dedicating their time among multiple work groups. So there is room for others. So it's focused, this group is focused on creating a more comprehensive approach to cancer screening for employers who have a workforce that might have barriers to screening, like for hourly employees who need support getting paid leave to get screened. Other initiatives that we're focused on include employee lunch and learns about cancer screening, creating a cancer screening friendly environment, and making the business case for time off incentives for screening. The image on the slide is also a product of the work group. We are almost finished creating the Colorado Employer Cancer Screening Toolkit. We're putting the finishing touches on it right now. And the future direction of this group includes working more with strategic partners in rural and frontier counties, and also seeking out small businesses to support, as well as engaging chambers of commerce. And for this particular work group, we do have a mini grant from the coalition supporting this work. So thank you, Christy. Next slide, please. So the third work group is also comprised of 8 members, and they're focused on providing support to clinics, mainly primary care clinics, regarding strategies to increase CRC screening and reimbursement. This group is starting to gather information about what clinics and providers need to increase colorectal cancer screening. And once they determine what is needed, they'll be able to take an inventory of all the provider-facing resources available to create or adapt materials to address the needs that are discovered. And for the future of this work group, we see more of a focus on evidence-based interventions that clinics can use to increase colorectal cancer screening, like providing clinic-focused resources for follow-up colonoscopy and facilitating reimbursement conversations with Medicaid. Next slide. All right, so if any of this sounds interesting to you at all, there's a few ways you can engage. You can contact Meg and I directly. You can go to the the coalition's website and find the colorectal cancer task force. You can submit a request to become a member of, or to get on our distribution list. Membership is open to anybody, but so that we know that we can communicate with you, get on the distribution list and get on the calendar invite. And then once you get your feet wet, we encourage you to participate in a work group that kind of aligns with your priorities. And if you are an employer, a clinic, a provider that do have aligning priorities, we would love to partner with you in this work. So please reach out. And thank you from Meg and I.
Great, thank you so much, Ian and Meg, for all of your work. It's insane how much work the task force is doing right now and all of the great things. So please, please, please get involved in the work. Christy put the link in the chat for the Colorectal Cancer Task Force webpage on the Coalition's website. And that includes Ian and Meg's contact information and some other information about what the task force is working on. And then also, because I'm not hugely tech savvy, I put a link to ACS Colorado's Facebook page that includes some photos of Ball Arena, Mile High, and DeVita that are all lit up blue this week for Colorectal Cancer Awareness Month. So it looks pretty cool. So thank you to all of our partners that are doing that. And if you are lighting blue, if your organization's lighting blue, please take pictures, please send them to the task force, to the coalition. We would love to share them on social media. So, all right, now we have about 20 minutes left for discussion, questions, conversation. And so in the chat, everyone probably noticed Andy and Dr. Karlitz talking a little bit around personalized screening. And I think with the huge emphasis that we are all having right now on health equity, this is becoming a lot more of a conversation. So Dr. Carlos, do you want to summarize some of your thoughts around kind of personalized screening or population specific based screening based on risks?
Yeah.
And thank you.
Yeah. I mean, we actually wrote a paper about this that we tried to make the argument that you should be using incidence rate thresholds in a population to make a decision about screening in that population, as opposed to just like a standardized age. So instead of just saying, oh, age 50 for everyone or age 45 for everybody, you could actually say, in a certain population, if the incidence rate is X, that's when you should begin screening. Like if that incidence rate is reached at age 42 or 47 or 50, that's kind of when you would initiate screening. That concept did not go over well with the peer reviewers, and we basically had to take it out of the paper. But I think it's a really important point, because it's really, there are definitely disparities that are going to arise if you subject different populations to age 45 or 50, whatever it is. Let's say it's 45. There's still going to be populations that have a much higher incidence rate than another population, and so you're gonna the population with the higher incidence rate is gonna suffer, and maybe they really need to be screened at age 42 or 43. But then the question becomes, how do you define a population? Are you talking about like a state population? So you're using cancer registry data. Are you talking about a region within a state? Are you talking about one localized community? So I think once you start, thinking about the complexity of this, it would be kind of hard to institute this in a national policy. But what I would say is that state cancer registries have excellent data on cancer rates within their state, and they really have to keep an eye on pockets where rates may be a lot higher than somewhere else. So for example, we identified this really high rate of colon cancer in the Cajun population of southern Louisiana. That's a genetic founder population. So that population deserves special attention because the incidence rates are very high, and there's a really high burden of early onset colon cancer there. So maybe that population is similar to Alaska Natives, and they need to be screened at 40, not 45. But I think that it does make a lot of sense to go after these more discrete specific metrics to determine screening age, but I just don't know if we're there yet. I think we're, as a nation, we're having a hard time even implementing a 45 screening threshold. I mean, I think that's going to happen, but it's taken a long time. I don't know what other people think about that, but that's my opinion.
Yeah, do any of our other presenters have any comments on that? Andy, I'm sure you do.
You're like Andy before you just jump in. I think you're right, Dr. Carlitz. I think one of the things that we hear, particularly in the advocacy community, is even that pullback to 45. I think there's a lot of emotional response that's not going to pick up, some of the groups that you've talked about. But I think within that data subset of especially 40-year-olds, there seems to be even some really good compelling evidence and data. But I think your point around how do you define a population and what does that look like and live like is something we have to consider. I do think for the average population, knowing about how population guidelines are really approached and what it takes to move, that it is pretty much a Herculean force. So I think you're right, even though the 45 data is very compelling, there's still a lot of discussion, especially not always in a resource-rich environment, about where to put the funds when we look at guideline pieces as well. So I do think that this discussion of when to start screening is huge. And I go back to something that I think Dennis Anand had said too, and I know we're talking about average risk, but Dennis was always a real advocate to remind us that even knowing your family history, and you should probably be starting screening earlier. If you have signs and symptoms, half the time patients aren't getting the workup that they should get, even if it's recommended by doctors. So there's still a lot to do really before 45 for a huge number of people, that there are guidelines and there are already measures to start screening earlier. But I do think, Jordan, that whole idea of that really personalized approach. And then the other side of that coin is then that population-based guidelines are really about everybody. If we do personalized, some people might even start later than a certain period of time. And how would we, again, really think about community, and how should everyone really think about movement on just based on race, ethnicity, age, and other sort of lifestyle factors. It's a lot to unpack, but it's definitely interesting timing to be sure. So I love that. And Jordan, I thought it's interesting that the reviewers cut that section out of your paper.
Yeah, they really did not like that. I actually was like, yeah, I was really kind of forthright, and when I wrote it up, I was like, let's pick an incidence rate threshold for state, and when, you know, and depending on the age of the population, you know, where that incidence rate threshold is, that's where you would, that's the age that you would institute screening in that state. So it could be like age 42, 44, 47. They didn't like that. But I do want to echo what you said, Andy, about acting on family history and acting on symptoms, because we know that we could all do a better job of identifying patients earlier. And I think when you're talking about people under age 45, obviously there are going to be some patients that have absolutely no symptoms and no family history that you would never identify unless, you know, you lower the average risk screening age to like 40 or something like that. But a lot of patients are going to have some symptoms and some family history. And if you could act on those things and make sure you take an adequate family history, you could go a long way to identifying people earlier and making sure that they don't present with advanced stage disease.
Mm-hmm. Exactly.
Great, thank you both. Andy, I do have one question for you, or thoughts from everyone that kind of shared. So looking at the Colorado data, we see the huge drop off in cancer screening for our uninsured populations. Huge compared to any other kind of demographic, the way that you had it broken down there from CDPHE data. I mean, what can we do to address that? And I think back to Mary's kind of comment earlier about, you know, should we be looking at different screening tests? Do we need to focus on different communication? Why do you think there is such a big disparity there, and how can we address that? And Meg, I'd welcome your thoughts from CDPHE too.
Yeah. So I think that there are a couple different things, and I know that Taylor from CCHN and a couple other folks are here. I think one of the things that we do have going for us is in FQHC and different types of safety net settings, we are seeing like UDS measures, and people are really taking this on. So I want to say there's a lot of work that's happening, but we also know not all uninsured people have a primary care medical home. We know that that's not always happening. So I think that driving that this is a preventable disease, that this is something that is common. I think I was on the phone with Dr. Elzinga from Salud Family Health Center, and he was talking about even when we work with legislators or we work with a number of people, even in every community, people are really still not clear that colorectal cancer is as common as it is. And I think Christy showed that good data. So I think we're gonna have to keep the conversation. I think we're going to have to just really, with the awareness and the outreach and talking about prevention, I do think that idea, and I have to say I'm a convert. I used to really only talk about colonoscopy, and I think, Mary, your point about all the different screening modalities are a good one. We're really going to have to like land there and see it. So between all the stool-based approaches, access to colonoscopy, hopefully blood testing will be up on the docket fairly soon. CT colonography has a place. I do think, especially in tandem, when we have CT colonography that has a colonoscopy follow-up right in the same appointment area, there can be great capacity and great utilization even for all of those. But especially for the medically underserved, I really do think stool-based testing has a lot of opportunity. But the thing is like one and done doesn't really, it doesn't work. It has to be a program that's followed up on every year or every 3 to 5 years. And so tracking. And then I think what the coalition is doing right now, right? Ian and Meg and team and Christy talked about it right now, those drivers for making sure we have a sustainable program. I mean, we're relatively young for a statewide program for something that's so common, but we still are relying on grant and state funding. There's no way to keep a coordinated effort if we don't find sustainable funding through either small P, big policy related type issues. I think the other thing is a follow-up. So Meg and Ian both talked about having that capacity for follow-up colonoscopy. So even if we do use stool-based testing or blood testing or CT, all of it really yields needing colonoscopy. And within our state for the medically underserved, we really, even in our statewide program, don't have resources that way. So we're going to have to continue to drive, and I would encourage everybody to be a part of that. And I do think what Christy talked about is those policy around barrier reduction, around all of these access components. It's going to take everything to really like move this along on some level. But I think at the end of the day, it still has to be about having a conversation. I mean, breast cancer has done an amazing job. I mean, they're our leader in so many ways to think about how to norm, how to talk about it, how to make it really part of the discussion. And I think lung and colon really have we have a long ways to go. And so these sort of forums, and then getting out in our communities and making it happen all year long, I think is going to be huge. But I do love that our statewide coalition and our task force is really, I think to your point, Allie, picking up on many of the things that are going to help propel, and we need more muster behind that.
Any other thoughts and comments from anybody else?
One of the things that we've noticed being from a QHC is, and for doing this for a really long time, working with Andy for years and years, with doing the screenings and doing the follow-up, and not having somebody doing the navigation for the colorectal and having that follow-up constantly to make sure that they're coming back in and getting those, whether it be the fit tests or going back in and having their colonoscopies and making sure that they're getting them, and having somebody to actually call them and making sure that it's being done and following back up with them all the time. It has to be that conversation, it has to be that education, and not having somebody to do that with them all the time, it doesn't get done. So even if we don't have the funding to actually get them in to do the colonoscopies, having that navigator to do that follow up and making sure that they're just getting any test. Any test is better than no test. And I know that we're reiterating that a lot right now. And that's got to be it.
I agree, Casey, and I want to say thank you to all of you and Jill and everyone who's out there, because that having you all in the field. And I think that one of the things that early on in CCSP is when we talked about even paying for the exams and paying for the treatment, most of the GI centers said, we're not working with you unless there is a navigation component. And it was sort of a happy accident that navigation really became, but it really is as essential as paying for the exam to get really people there and to get moving forward. So I agree, and I know Jill has a shout out there too, but I just want to say thanks to Casey and many of the navigators who've been with us for years really working on this. And it is sort of on some way like we've been working on it for years, but we're making movement. I mean, it doesn't always feel that way, but I do feel like that there are gains even within some of the subpopulations of that uninsured group that are big wins. But you're right, Allie, we have a lot of ways to go, but you're right, Casey, like getting people on the ground to really mobilize is going to continue to be key, just as much as paying for the exam.
Yeah, and I think just to add to that, Victoria made a great point that a lot of people without insurance don't have a provider, aren't connected to a clinic. And so that outreach that everyone is doing from the FQHC standpoint to educate that there is an affordable option for folks without insurance, or you know, that there are some services and programs and resources that can help support screening. So I think that that's a great point, Victoria, too. Like, how are we reaching the people that aren't engaged with the health system currently too?
And Christy, I know we have some of the people on the line that we'd probably like to get engaged. And I think one of those right now is doing a buy with KKTV. Christy, do you want to share a little bit about how the coalition is doing that, even from a broader outreach standpoint?
Sure. Yeah. So we were approached by KKTV to help improve cancer education and cancer screening knowledge in the southeast part of the state. And so we are working on a targeted email campaign with a few TV kind of commercials to supplement, as well as some display ads, with the ultimate goal of the call to action being like, talk with your doctor about the right schedule and the right test for you to go in for your colorectal cancer screening. And we're going to pilot it with colorectal, and then do some different messaging in April and a little bit of different messaging in May for some different cancer types. So it should be a good pilot to see if we can try to get more people scheduled in for the cancer screenings that they've been delaying due to COVID. So if you would like to, that could be one thing. Ian and Meg, I need to reach out to you for the awareness work group. But that would be a way, if you're new to the coalition and want to engage, this could be really a really fun program to get in on the ground floor on.
Yeah, I think that that's a great opportunity, especially kind of in that more rural area of Colorado, Christy. So that's super exciting. We do have one question in the chat that I don't want to lose here with just a few minutes left. And Dr. Karlitz, this would probably be the best question for you, is what role does genetic testing have in all of this, with when folks should get screened or when folks should pursue genetic testing?
Yeah, no, that's a really good point. So, I mean, there are a number of colorectal cancer syndromes out there. The most common would be Lynch syndrome, which is autosomal dominant, and about 1 in 279 Americans are carrying a Lynch mutation. And so these patients could get colon cancer at an earlier age. They could develop other types of cancers like uterine cancer, ovarian cancer. So it's really important to get a family history and determine whether people meet family history thresholds for genetic testing. So that could be done in a clinical situation. So even if a person doesn't have cancer themselves, but they have a strong family history, they may meet criteria for genetic testing. And then obviously if they have a cancer, they may also meet criteria for genetic testing. But the bottom line is, if you're dealing with a syndrome, like Lynch syndrome, for example, you are going to have to get screened way earlier than 40 or 45. I think the current guidelines are, they kind of sometimes change a little bit in the NCCN, but I think it's before age 20. I think age 18 for Lynch syndrome, but I'd have to double check that. But you need to identify these syndromes because you're talking about developing cancer at a very, very young age. And then the question is, you know, in Colorado, I'm not sure what the reimbursement is for that, for genetic testing. I know that in Louisiana, we had published a paper in the American Journal of Gastroenterology a few years back showing that testing for doing genetic tumor testing in early onset cases was like dismal. The rates were really low. And we actually brought that information to our state legislature, and we were able to get approval from the Department of Health for reimbursement for genetic testing in young patients. So that was a great win for us, but I'm not sure what the status of that is in Colorado, particularly for underserved patients, Medicaid patients, uninsured. So maybe Andy would know, or someone else, I'm not sure.
Yeah, so I think, Jordan, you're right. And I know some of the policy groups like Fight CRC and NCCRT are really working on stronger reimbursement rates. Right now, Medicare doesn't reimburse, which is a huge bummer and a total loss. Medicaid does reimburse on some level, but I think in Colorado, one of the things we're having some issue around our capacity for genetic counselors who will see patients and have an opportunity. And so that's been difficult. And even some of the telehealth groups right now aren't always accepting all types of insurances as well. So you're right. And it's very state by state centric around what happens. The one thing I will say though, is we have developed through CCSP, and I'll have Elsa and Chloe put in the website, a specific instrument and tool that we worked with Dennis on in Heather Hampel. We're working with an advisory team from throughout the country to develop that really identifies actionable and screening cancers. So it's not all the NCCN guidelines, but it's the most sort of robust set of guidelines that have actionable steps that would mean referral to a genetic counselor and then to genetic testing. And I think, as Jordan said, there are certain areas where the testing itself, the reimbursement can be funny, but even sometimes with the medically underserved, getting the testing covered through charitable donation is easier. It's just the time for the genetic counselor that can be difficult. So the Cancer Coalition has given CCSP a fund last year that helps support this sort of work. We also had funding from a couple other groups where Denver Health and Compagre Medical Center and a couple other teams are really implementing this statewide approach. And Grand Junction and Marillac and the team, I think Carla's on today, really implemented this full scale to validate this type of approach. If you're interested in seeing the tool and the instrument, as well as the ancillary education materials about how to implement, that's on the CCSP website. We do have some money for technical assistance in this area. But again, that genetic counseling and testing piece is still a little murky. And that's, I think, an area where the coalition and our national policy folks are really going to have to do some extended work too. And we're really, I just have to just say a shout out for Jordan. I think Jordan and team have done a lot of great work throughout the country, and it's great to have people from other states really coming into leadership in Colorado too, so we can kind of get a sense of how to move the dial. And we already have so many great leaders and champions, but Jordan, I think we're really excited about having you here. And I know Ian had mentioned the Medicaid reimbursement rate. So those are some things that you guys have had progress. So I think we have some really good work with New Blood and with all of those who've been around the table for a while to really elevate this sort of testing, that screening elements, and paying good reimbursement rates as well. I think is going to be key.
Yeah, no, thank you so much. And I should say that in like Louisiana, one of the things that allowed us to kind of move things was that our state colon cancer roundtable had a really good relationship with the Department of Health and with our state cancer registry, which is part of the SEER program. So we would all work together. It was almost like a triangle. And so that really helped back things. Like we were able to get a lot of the data from the cancer registry, and then we were kind of proactive. The roundtable is proactive with the Department of Health to let them know what some of our concerns were. And so it was that kind of relationship between these three entities that allowed us to get some of these things through. Also, I mean, colorectal cancer is colorectal cancer in Louisiana, I think it's like the number 2 or 3 state for incidence rates in the United States. So obviously it's clearly a problem in every state, including Colorado. But in Louisiana, the rates I think are about 20 to 30% higher than other states. And so it's just a major source of morbidity and mortality.
Mm-hmm, definitely. And I do want to do a shout out. I know they didn't maybe introduce as much, but Meg and Ian, and I know Becky Seelig and several other, I think some WWC folks from CDPHE. Our state health department is a huge partner in this work. And Randy Rycroft transitioned from our tumor registrar, but I think John Aaron and team have been really responsive. So Jordan, really looking forward to integrating you into the group. So nothing like having you on the panel as one of your first opportunities to engage with Colorado, but might as well jump in, right?
Yeah, no, this is great. I can't wait to get there. So next week.
Good deal.
Yeah, we're certainly looking forward to seeing your face more frequently on meetings like this. So thanks for joining us.
Oh, absolutely. Thanks for the invitation.
All right, well, we are a few minutes over. This has been a great discussion. So thank you to all of our panelists, all of our participants. Thank you to everyone. Another reminder to complete the evaluation. I just popped it into the chat again. And certainly let us know, let Chloe, let Andy, let Elsa know if you guys have other thoughts about what you would like to hear in the future. And again, thank you so much to our panel. Please reach out to Ian and Meg and join the task force. And we look forward to seeing all of you again soon. Thank you.
Great.
Thank you,
Ellie, for moderating.
Bye. Thank you.
Bye, everybody.